Next is about thrombophlebitis. Now, that word thrombophlebitis means a clot formation in the beginning and produced due to the inflammation of the interior of the vessels. And the causes could be either trauma, the most commonly it is a trauma, hypercoagulable status, that's abnormalities of the clotting factors like which can be the cause for that, and venous reflux were the three main causes. Of course, prior to 1993, only three inherited hypercoagulable factors had been recognized earlier. That only that abnormality of the thrombin, antithrombin, protein C, and protein S. But now, with the latest forms of the investigations, around 60 to 70% of the thrombosis can be identified as specific inherited thrombophilia, abnormality of the platelets with the inherited hypercoagulable status, and they are now categorized into 5 categories: qualitative or quantitative defects of coagulation factor inhibitors, or increased level of function of coagulation factors, hyperhomocystinemia, and defects in the fibrinolytic system and altered platelet function. Of course, these are all the results of investigations which suggest about a familial tendency of or a inherited tendency of a person to get the thrombophlebitis frequently. So those who get thrombophlebitis episodes without any specific known causes, they could be under any of these 5 categories which need to be investigated, and the investigation is a very elaborate process. Most of the times it may not be necessary as such. But as far as the common causes are concerned, the most common cause is a indwelling catheter into the veins, maybe intravenous administration of the drugs. When you put in a cannula in, and the cannula is kept there for a longer period, like more than 2 to 3 days, the chances of the thrombosis are very high, and 80% of the patients have particularly superficial vein thrombosis, they are seen due to the catheterization, either the simple cannula or maybe the catheters which are introduced as well, the other major procedure. The other predisposing factors like persons who are sedentary lifestyle, like prolonged sitting, immobilization or dehydration, as in long flight, long surgery, or prolonged bed rest due to any conditions also can say, as in case of the deep vein thrombosis, with the thrombophlebitis also, superficial vein thrombosis also is possible. The same factors which are responsible for the deep vein thrombosis like pregnancy, oral contraceptives, tamoxifen like drugs also can induce the or maybe a triggering factor for the thrombophlebitis. Genetic thrombophilia or underlying malignancy also can lead to hypercoagulable status. Viral diseases, particularly now these days the COVID-19 and chikungunya virus infections have also been identified to be one of the triggering factors for the thrombophlebitis. Malignancy of any sort can also be the cause of the thrombophlebitis. The typical clinical presentation of a thrombophlebitis after the cannulation would be, once you have introduced the cannula, after 1 or 2 days the patient may have some pain, and there could be a thickening, cord-like thickening of the vein at that area, and the extent could be anywhere. It could be a short distance or long distance, and there could be moderate pain. At times it could be spontaneous without any injury, that there could be evidence of inflammation, and which can be temporarily for 1 or 2, maximum 1 or 2 weeks, and then it subsides. There could be a reddish superficial subcutaneous swelling due to the inflammation of the veins. Later, when it heals, it may even produce the changes in the skin. The skin may have peeling up. So patient may come in any of these 3 presentations. Typical presentation is pain and maybe either low grade fever or no fever at all, swelling as such. Complications, of course, most of the thrombophlebitis conditions, more than 90% of the thrombophlebitis conditions, they heal spontaneously without any specific treatment. Maximum could be a symptomatic treatment, but rarely it may produce a complication of sepsis, or extremely rarely a superficial vein thrombosis may extend into the deep vein, and a deep vein thrombosis also may occur as such. Treatment, of course, there is no specific curative management. The usual standard treatment protocol is maintain the hygiene and asepsis, clean and with antiseptics like Compression bandage also may be advised as a symptomatic treatment. Drugs like NSAIDs to reduce the pain also could be used. Local thrombolytics like thrombovar, one of the commonly used drug, or streptokinase, such drugs also could be used for locally, which can be reducing the pain or distress within a short duration. Even without that, it will heal, but these are certain of the symptomatic treatment. Systemic anticoagulants also may be rarely necessary in a patient who has a high risk of deep vein thrombosis, but most of the times these protocols are not required. And as far as we see, particularly the cannulation induced thrombophlebitis, triple-glucose, which is often prescribed as a postoperative treatment protocol, would be enough. Rarely you may require a Dashangal application for 1 or 2 days, which will resolve the condition, but that's one of the common conditions. Next part which we discuss would be a thromboembolism. Embolism, as such, the word embolus means a moving solid part in the circulation, solid particle in the circulation, and it could be produced due to multiple causes. So embolism is a very broad word where a solid particle moves in the circulation, and when a solid particle moves in the circulation, it may get into the capillary bed anywhere, and that capillary bed may become blocked. So the complications produced due to the embolism is either depending upon the size of the clot and the location of the clot, that location of the solid particle embolus, that size of the embolus would decide which type of, or how much of the area of the body would be involved, and the type of the functions, like if the embolus affects the carotid artery or artery supplying to the brain tissue, the patient may have a neurological deficit. If the embolus involves renal arteries, then there could be renal pathology. If it involves the coronary, then there could be a coronary event, and so on. So once a solid particle is present in the circulation, it can produce the complications anywhere, and how much of the complication, severity of the complication will depend upon which of the organ is involved, as well as the extent of the damage. Extent of the damage is proportionate to the size of the embolus. The common types of the embolus, the most common type of the embolus is a thrombus, that's a blood clot which occurs within the circulation, and the other causes. So usually the thromboembolism is the most common cause, and majority of the patients are cerebrovascular accident patients who come to the hospital. They have a thromboembolism as a triggering factor, that where the blood clot, and in general any solid particle tends to move in the direction with the least inertia, like because they have a mass, they would have the inertia, and hence they tend to move in the straight direction, and they avoid that turning movement, and a embolus which enters, which is pumped out from the left ventricle, has a high chance of getting into the carotid artery and reaching into the intracranial area, and hence when you look at the clinical presentation of all sorts of embolism, thromboembolism as well as the others, the most frequent site involved would be the central nervous system, the brain and central nervous system, and hence most of the patients who present with a stroke, they would be having this thromboembolism, which could be primarily from heart, or which could be produced from the heart. Whereas the other causes of the embolism are fat embolism, which is often produced due to the fracture, or sickle cells, where the patient may have sickle cell anemia, where the RBC shape is altered and it can become a mass-like, and it also can produce this. In pregnancy, a pregnancy-related thromboembolism, particularly amniotic fluid, which may leak during the labor, or the fetal parts like skin parts, hair parts of the fetus, also may get into the circulation of mother, and it can produce an embolism, which also is not very frequent but can occur. Tumor embolism is one more. Any tumor, particularly vascular tumors like sarcomas, they have a high tendency for the embolism. Gestational diseases like hydatid form mole, where it's again a product of fertilization, where ectopic fertilization also can occur, and this also can lead to some breakdown materials which can reach in bacteria or fungi. Septic pathology, patients who have septic pathology, it also can result in, and particularly the septic pathology involving the myocardium, like myocarditis or endocarditis, the chances of embolism are very high. Then hydrated cyst also can result in emboli. Any foreign material which can enter into circulation, majority of these may occur during any procedures like catheterization procedures or angioplasty and so on. The stents which are placed there, they may get displaced and they may produce that. Air embolism also is another of the conditions. So we will not go into the detail of all of that, but certain of the conditions which have some clinical significance, we will discuss about them. And among them, the one of the condition which has certain significance is a fat embolism. Particularly the fat embolism is one of the complications which can occur due to a fracture, particularly a fracture of thicker bone like the femur. The chances are very high. And it is also true that if the fracture is gross, if there is a comminuted fracture, multiple particles of the bones have occurred, that also can result in fat embolism quite frequently. So incidence of the fat embolism after a gross injury to the body, either the fracture or even without the fracture, soft tissue injuries, gross injuries also can produce a fat embolism. Any prolonged surgery which involves tissue handling for a long duration, prolonged tissue or maybe extensive tissue handling also can result in fat embolism. Some of the fat particles may get into the circulation, and with the vascular surgery the risks are quite high. Now, as far as the identification, the historical facts about the fat embolism was that the fat embolism was identified in 1873, and the first person who made the diagnosis is Ernst von Bergmann. Whereas as far as the present day's knowledge about the fat embolism is concerned, fat embolism can occur to a small particles of the fat can enter into the circulation during any surgical procedure, particularly nailing procedures of the bones. The chances are quite high, which can be demonstrated with the echocardiography, but they may be asymptomatic. Particularly the embolism, fat embolism in small quantities, it may not produce any clinical symptoms. It may be just asymptomatic. That could be mild embolism involving the pulmonary bed, and temporarily the patient may or may not have mild symptoms, and then it may not produce the issues. Whereas a pronounced embolism signs would be seen, that the clinical signs of damage to the tissue due to the blockade would occur only in 0.5 to 11% of the cases, particularly after orthopedic surgery. So one of the major issues in orthopedic surgery is fat embolism. The other causes of the fat embolism are the blunt trauma, which may not even involve the bones, pancreatitis, diabetes increases the chances of fat embolism, burns, the liposuction, cardiopulmonary bypass surgeries, decompression sickness, parenteral lipid infusions, and sickle cell crisis, pathological fractures also can produce the fat embolism. And most cases are, as I told you, asymptomatic. Pulmonary embolism is the common clinical presentation. So whatever the clinical presentation is presented, it's exactly like the pulmonary embolism, which we have discussed in the previous session. Pulmonary embolism and its presentation we have discussed in the clinical earlier sessions. Like to identify the fat embolism, because they are asymptomatic and they are may present with exactly the same signs of pulmonary embolism. The other common cause of the pulmonary embolism is deep vein thrombosis, where again the similar phenomena can occur. To make out that there is a clinical criteria. The clinical criteria is again major criteria and minor criteria to make the diagnosis. As in case of the deep vein thrombosis, here also the criteria are followed for the clinical diagnosis. The clinical diagnosis is symptoms and radiological evidence of respiratory insufficiency. It is the same criteria which we have discussed for the pulmonary embolism. It's a part of the same as such. Along with that, there is some extra features. The extra features are the cerebral sequelae. unrelated to head injury. Patients presenting with cerebral symptoms without head injury or other conditions, petechial rashes mainly in the axilla, or minor criteria are tachycardia, pyrexia, retinal changes of fat or petechia, renal dysfunctions, jaundice, acute drop in hemoglobin level, sudden thrombocytopenia, elevated ESR, or fat microglobulinemia. That patient, if at all you look at the urine examination, there could be fat microglobulins present in the urine. These are the other evidences which could be seen in a patient fat embolism. Once the fat embolism has occurred, the diagnosis would be chest X-ray findings may not be very accurate. The chances of missing them are quite high, but CT is better suited for making the diagnosis. In the CT diagnosis, there could be mainly three patterns which could be seen: either a ground glass change, as you see here at this area, ground glass change which can be limited to certain areas of the lungs and have a very clear-cut border, or there could be interlobular septal thickening. The septal interlobular septi may become thickened, which may have these higher densities, or nodular opacities, these nodules which also could be presented over there, and the pulmonary artery occlusion may not be seen quite frequently. So CT is a better tool as such. When it is in the brain, the invasive brain, again it produces the multiple edema spots, which is also called as a embolic shower, because of the emboli and multiple opacities seen due to the lack of circulation. Multiple infarcts seen throughout in the deeper area of the brain are characteristic. This, of course, you have seen in many of the patients whom we have treated, where there could be multiple emboli seen as such. Maybe in the patient who is at present in 205, his CT also, he has an aneurysm also. Along with that, there is a multiple emboli changes. It's not fat embolism, but multiple emboli changes, that showers are seen in that patient's CT. As far as the treatment is concerned, the most important is prevention is the most important aspect of the treatment. Particularly identification of the risk conditions. Identification of the risk is particularly in orthopedic surgery. Patients who are subjected to orthopedic surgery with the gross fractures, the prevention is one of the important issue. For the prevention, earlier in the olden days, methyl alcohol given 5% alcohol given intravenously was practiced earlier. So persons would be enjoying that alcohol without drinking, just given IV, was the practice. But now it has become obsolete. Earlier, administration of the alcohol prior to the orthopedic surgery was a practice, but now it is obsolete. It is not done now. The present is heavy molecular dextran. The polymers of the dextran are often used. Glucocorticoids also are given. Heparin often is used in patients who have high risk as such. In the postoperative period, continuous IV fluids, oxygen and steroids are usually given to avoid or reduce the complications. Once the embolism has occurred, then the treatment will be depending upon the type or area involved. Like pulmonary embolism, you have considered the treatment earlier. Then embolism into the intracranial structures, the patient would have neurological deficit, and then that neurological condition needs to be treated, so on. And renal pathologies, they need to be treated as such. So that protocol of the treatment would be depending upon the organ involved and the extent of the damage involved. So that's about the fat embolism in brief. The next part is about the air embolism. Air embolism is a air bubble which can get into the veins and then can produce the complications. Traditionally, it has been estimated that more than 5 milliliter per kilogram of air displaced into the intravenous space is required to produce significant injury. So earlier it was believed that something like less than 100 ml of air into the veins would not produce the damage and it can get absorbed. But now it's known that as small quantity as 20 ml of air injected into the vein also can produce the complications as such. many of the Bollywood cinemas, one of the modes of homicide, murdering, would be injecting air into the veins. In Amitabh Bachchan picture, there is one of that Amitabh Bachchan picture, Kalia. That in that you have that kind of incidents where the the murder homicide is done by injecting air into the veins. So, but there it was a very small syringe, so maybe 5 ml syringe was used for killing. But anyway, it's whether it is true or not, that other part. But even now, known now that even small quantity of like 20 ml of air also would be enough to produce the damage. Earlier it was believed that the air injected in small quantities would be absorbed in the body, air bubbles would be absorbed in the circulation. So anyway, that's around that condition. Our injection of 2 to 3 ml of air into the cerebral circulation, if it directly into the cerebral circulation, can be fatal. Particularly it occurs during the neurological surgeries. Neurological surgeries, when we use suction and maybe at times the air flow to clear the tissues, there is a possibility that the air bubble may get into the circulation, and that air bubble could be enough to produce a fatal complications. And even 0.5 ml of air in the left anterior descending coronary artery, if the air bubble enters into the coronary artery, that also can produce a fatal complications of ventricular fibrillation. So air present in the circulation can occur, and the air can be entering into the circulation when there is any direct communication between a source of air and the vasculature. Now with the laparoscopic surgeries or other endoscopic surgeries or endoscopic procedures, where usually we inject the air in to have that gap, space between the lens of the camera and the tissue. By accidentally suppose that air gets into the circulation in a raw area, and which is quite one of the high risk in case of the laparoscopic surgeries. Laparoscopic surgeries, you will be injecting air or carbon dioxide into the tissue space, so that your camera would have some space so that the images are seen. But at times it can result in that injection of the air in, and hence that can be one of the causes. The other cause for thromboembolism is a pressure gradient developing around the body, particularly in the person who goes into the deep diving and he remains underwater for quite a long time. If he comes out suddenly, because the person would be taking that cylinder, the compressed air in below the sea, where the pressure would be quite high because of the added pressure of the water column, and at a high pressure the air is dissolved in the circulation in a particularly non-soluble air. That's nitrogen is dissolved in the blood with a higher concentration. Once the person comes to the surface suddenly, if he comes to the surface suddenly, this dissolved air or nitrogen can produce bubbles. It can just get bubbled, as in case of soda bottle. In the soda bottle, the carbon dioxide and other gas is pressed in or dissolved in higher concentration under pressure. So once you open the bottle, the pressure becomes lower, and there would be multiple bubbles formed, because in the lower pressure the solubility of the gas substance in the water would be lesser, so bubbles are formed. Similar bubbles can form if the situation occurs, if the person comes to the surface after diving in a sea for a long duration. If the decompression is faster, that can result in the bubbles, and that kind of a disease called as Caisson's disease, Caisson's. Caisson's disease is one of them. Now, of course, these days the precautions are taken. The patients are persons who dive in, they are gradually decompressed. Or similar decompression, pressure gradient also can occur in the persons who fly in height as such, like air flight as such. Those who fly in aeroplanes, the pressure in the aeroplanes are maintained at a higher level than the surrounding area. so or it's maintained at the same level as that of the atmospheric ground. The pressure at the higher altitudes is lower. Suppose if a person comes out of the airplane suddenly out of without really having that decompression procedures, there can be the same issue. Air bubbles could form because the pressure outside the area would be of a lower pressure. So, suppose if there is a plane expert, or if some person jumps from the high altitude from a plane, he may die because of the air bubbles in the circulation than really injury to or fall and injury. But of course, this would be only when it is more than 500 meters high. If it is less than 500 meters high, as in case of the helicopters, low flying aircraft, these big instruments like helicopters or so on, or maybe the smaller aircraft, this is not an issue. So if it is at a higher altitude than more than 500 meters, then the decompression procedures are required. So these days, those safety precautions are taken so that that kind of a complication doesn't occur. Now, when the venous embolism occurs, the most cases of venous embolism are venous embolism. Air embolism are at the venous side, and they may not get recognized quite frequently, maybe in these like surgical procedures, because they present with the clinical presentation of either cardiac, pulmonary or neurological dysfunctions. Most of the times in the post-operative, our usual issues like surgical procedures where other procedures where compressed air is used, this may not get recognized, and patients may present with the signs involving any of the other organs of the body, like cardiovascular signs like dysrhythmias, murmur, that heavy intensity murmur, high intensity murmur, which is also called as mill-wheel murmur, or hypertension, myocardial ischemia, ST changes, or pulmonary artery hypertension, increased central venous pressure, circulatory shock or cardiovascular collapse or death also can occur due to the air embolism. Pulmonary features like adventitious sounds like rales and tachypnea, hemoptysis, cyanosis, or carbon dioxide concentration becoming reduced, and arterial oxygen saturation also can be reduced. Hypercapnia, carbon dioxide could be increased as such, increased pulmonary resistance or pulmonary edema or so on. Neurological deficit like acute and altered mental status, seizures, transient, permanent or focal deficits occurring in the patients, or consciousness being altered, coma. Now, most of these complications can occur after any such surgical procedures. They are now identified as some other complications, and this may be missed as such. So, accurate diagnosis is always difficult. Air embolism accurate diagnosis is difficult, and treatment protocol. The ideal treatment, if at all you have identified the patient of air embolism as such immediately, like over the operating table, you can make out that there is air has got in. One of the immediate procedures by which the vital organs can be saved is by changing the position into Trendelenburg position. Head end has to be lowered so that the air from getting into the right side of the heart or pulmonary arteries is reduced, so that the vital functions are maintained. Then the other part would be only managing the organ dysfunctions. As the patient has the organ like cardiac or pulmonary, neurological, depending upon the intensity, the treatment has to be planned as such. All that important is precautions to prevent that. The next type of the embolism, and rather most common form of the embolism, is a thromboembolism. The word thrombus means a clot formed within the circulation. A thrombus within the circulation could be either on the arterial side or the venous side. The arterial thrombus is having a higher consistency or thicker consistency, and it will have maybe more of fibrin because the pressure is higher, the cells are squeezed out, and it is harder, firmer as such, and that's why in the books it is named as white thrombus. The word used is white thrombus for the arterial clot, arterial thrombus. But it's not that it is really white in color, it will be still red in color because the network would still have some cells. But compared to the venous thrombus, the cells are lesser, fibrin content is more, and it is firmer in consistency, and hence an arterial thrombus has a lesser chance of getting mobilized during circulation. Once the thrombus has occurred in the artery, it may block the circulation at that point, as such, depending upon the size, but that the clot moving from that spot to the other area, becoming an embolus, the chances are lesser. It's not that it will never occur, it can occur. But once the arterial thrombus gets an embolus, it has become mobilized, it may produce a circulation of a smaller artery further distal to that area. There will be the ischemia, or the artery will be blocked, and hence the clinical symptoms which occur in case of arterial thromboembolism would be depending upon the location in which the thrombus has occurred. Most frequently it occurs in the smaller arteries and the periphery. So most of the times it results in peripheral acute ischemia. Patient would have ischemic changes in the periphery, like the extremities, so on. Whereas a thrombus on the venous side would be softer because it is not squeezed, more cells would be present, and hence it has a higher chance of getting displaced. And once it gets displaced, it's always that generally maybe the venous thrombus moves towards the pulmonary bed from into the right side of the heart and into the pulmonary bed, and hence it produces a pulmonary embolism most frequently. Exceptionally, there could be a paradoxical embolism where the venous embolus may move into the left side of the heart if there is a patent foramen ovale or such left to right shunts as well. Then it may produce a embolism in the other part of the body. Now, the causes for the venous embolism, thromboembolism could occur as a result of deep venous thrombosis, which we have already discussed, with pulmonary thromboembolism. Arterial thromboembolism can present with ischemic stroke or myocardial infarction. Other thromboembolism, like depending upon the location, you may have systemic thromboembolism, cerebral thromboembolism, coronary, massive thromboembolism, where every organ of the body could be involved and multi-organ failure could occur rarely. And thromboembolism also can occur in the spleen or for muscle injury, thromboembolism with the coagulopathy, abnormalities of the clot, and hence the patient may have bleeding, cancer-associated thromboembolism, postpartum thromboembolism after the delivery, thromboembolic renal disease could be the different clinical presentation of the thromboembolism depending upon the organ involved. That's about the thromboembolism, and all that treatment protocol would be to prevent the thromboembolism. The risk patients, anticoagulants are given. Or one of the other common causes of the thromboembolism is having eddies currents. Patients who have either arrhythmias or valvular defects, they have a high chance of developing the thromboembolism. So prevention of that by either surgical correction or administration of anticoagulants or the platelet aggregation inhibitors like ecosprints, they are salicylic acid. They are frequently used as a preventive. So in a patient who has a hypertension and a high risk of atherosclerosis, the usual prescription would be salicylic acid, which would be quite safe and also have a cardioprotective role. So that's in brief about the thromboembolism and the blood clotting related diseases. Another similar condition which is some clinical significance would be disseminated intravascular coagulation or DIC. Now, disseminated intravascular coagulation from the practical clinical point of view has an importance in the obstetric practice more frequently than the others, but it can occur in other conditions too. It is defined as a systemic inflammatory response leading to activation of the cytokine network and subsequent activation of the coagulation. There will be generalized abnormality of the coagulation occurring in the body throughout as a result of some inflammatory response. Anywhere inflammatory response in the body can trigger this kind of a complication. Often it is produced after sepsis or major trauma, or it also can occur it can also maybe due to release or exposure of procoagulant material into the bloodstream, that before the coagulation of prothrombin into the circulation, which can occur in cancer, brain injury, or particularly obstetric cases. The most important from the clinical point of view is in the obstetric conditions. As far as the clinical data is concerned, it is estimated to be present in as many as 1% of the hospitalized patients, irrespective of the cause, and it occurs in 30 to 50% of the septic patients who have some sepsis in the body. And it's not only a single specific illness; it's a complication or an effect of progression of other illnesses. Patients who have other diseases and admitted in the hospital, they have a high risk of disseminated intravascular coagulation. So, in the ICU conditions, patients who are treated in the ICU, this chance is more, and hence, in the ICU treatment protocol, particularly if the patient is in the ICU for a longer duration and there is a septic pathology, one of the protocol is to identify a possible condition in the early conditions, or that pre DIC or before the full blown DIC has occurred. Pre-DIC is diagnostic criteria, and hence in the ICU protocol, once in 3 days there is a protocol of identifying clotting time, particularly that prothrombin time, INR prothrombin time is assessed regularly, and antithrombin activity also could be studied regularly, so which can help in early identification of the disseminated intravascular coagulation. So, in the general protocol of ICU monitoring, ICU management, that regular assessment of the INR, that prothrombin time at regular intervals, is a regular or general practice which can help in identifying the pre-DIC. And early identification of the pre-DIC and treatment with heparin may reduce the mortality and duration of the hospitalization, and hence heparin combined with the antithrombin and anti-inflammatory effects, it has both antithrombin effect and anti-inflammatory effect, and hence that's one of the general protocols. The other common associated conditions, as such, the most important, as I told you, is the obstetric complications like amniotic fluid embolism, blood placenta, hemolysis, elevated liver enzymes, low platelets, syndromes, eclampsia. All these can result in a DIC. It's one of the highly significant causes of the postpartum fatal conditions. Death occurring after the delivery. The other causes are sepsis or severe infection, including COVID-19. With the COVID-19, the incidences have now become more. Trauma, particularly neurotrauma, injury to the nervous system, either head injury or so on. Patients who have organ destruction, particularly pancreatitis, malignancies, solid disease malignancies, transfusion reactions also. Patients who have blood transfusion reactions also can develop this. Retained dead fetus syndrome, that's another of the obstetric issue. If the dead fetus is retained in the uterus for a longer duration, that also can result in DIC. Abnormalities of the blood vessels, like if there is a aneurysms, that aneurysm also can be a cause for the disseminated intravascular coagulation. Hepatic failure, severe toxic reactions after venom administration, that's one of the complications of antivenom administrations. Transfusion reactions, transplant rejections, etc. Heat stroke also can result in DIC. Hemorrhagic skin necrosis, purpura, fulminants like conditions. Antiphospholipid syndrome is a rare condition which also can present in the same. Clinical presentation of DIC is the maximum would be the bleeding, episodes of bleeding occurring from everywhere in the body. Subcutaneous bleeding presenting with ecchymosis and rashes, bleeding from the gums, bleeding from the rectum can occur, and even there could be adrenal hemorrhages, and that's seen in around 64% of the patients. Abnormality of the kidney functions, maybe sudden development of the renal insufficiency, studied under biochemical investigations or maybe the other clinically, could be in 25%. Hepatic dysfunctions in 19%, respiratory dysfunctions in 16%, shock in 14%, central nervous system dysfunctions in 2% of the patients. So clinical presentation is quite wide varying in disseminated intravascular coagulations, and the most reliable would be only the bleeding as such. The circulatory signs which can occur could be which may be presented as signs of spontaneous and life-threatening hemorrhage, sudden hemorrhages, subacute bleeding, or maybe diffuse localized thrombosis, particularly generalized thrombosis could occur. Bleeding into the serous cavities like pleura or abdomen also can be the presentation. Central nervous system symptoms may present as a non-specific altered consciousness or stupor. In case of this obstetric practice, the most common symptoms are either bleeding from the vagina, and then the central nervous system of the patient would have a altered consciousness, stupor, or many times seizures also. Neurological deficits also can occur. Cardiovascular signs would be hypotension, tachycardia, circulatory collapse could occur. Respiratory signs, there could be pleural rub or acute respiratory distress syndrome can occur. Then gastrointestinal signs also can occur, which can result in hematemesis or hematochezia. That's hematochezia, blood in the stools. Genitourinary signs like the patient may have renal failure, acidosis, hematuria, oliguria, metrorrhagia, uterine hemorrhage is the most common. The other easily identifiable condition is the cutaneous signs, where the patient would have a skin necrosis, that petechiae occurring over the area, or there could be this cyanosis which can occur in the, that's also called as acral cyanosis, peripheral cyanosis, which can occur in the extremities. These are the two easily identifiable clinical conditions, and in obstetric practice, observation for this petechiae and acral cyanosis is in the postpartum period is one of the essential protocols. Then the other symptoms which can occur could be jaundice, purpura-like conditions, infections, gangrenes, wound bleeding, and thrombosis also be the presentation. Investigations is mainly the platelet count would be reduced in around 98% of the patients. 98% of the patients with the DIC, platelet count would be reduced and it would be less than 70,000. Then global clotting factors, PTT and PT, that's the same prothrombin time assessment, would be enhanced in 50% of the patients. Clotting factors or clotting inhibitors also could be studied. Essay of D-dimer, D-dimer has become now more reliable and more regular in the practice after the COVID as such. Treatment is the underlying disorders have to be treated as such. It has mainly the basic treatment of DIC is vital signs have to be monitored and maintained. So vital functions have to be maintained by either supports like respiratory support or cardiovascular support as such. And the hemorrhage and thrombosis has to be documented. If there is a need for a replacement, the hypovolemia has to be corrected either with blood transfusion or maybe the IV fluids. The hemostatic procedures, they are also may be administered like compression bandage and so on. Blood components is the major treatment. Anticoagulation, heparin is the other part of the treatment in DIC. So that's about the DIC as such. Complications of the DIC can be quite serious and often it can become fatal. And the complications are acute kidney injuries, change in the mental status, respiratory dysfunction for prolonged period, hepatic dysfunctions, life-threatening hemorrhages, cardiac tamponade, hemothorax, intracerebral hematoma, gangrene and loss of digits, shock or death. Of course, death also is quite frequent in DIC in clinical conditions. So, obstetric practice, DIC is one of the very serious issues. Prognosis is if there is a idiopathic purpura, skin condition, the mortality rate is considered as 18%. Septic abortion and infection in the postpartum period, the fatality is considered to be 50% with best of the facilities. But where the facilities are lesser, the fatality rate could be quite higher. And major trauma conditions, the mortality rate could be doubled. It could be even 100% in severe conditions. That's about the DIC. The next condition we discuss would be aneurysms as such. Aneurysm is defined as a dilatation of a vessel, and depending upon the pattern presented, aneurysm is diagnosed as a saccular or fusiform, which are also considered as true aneurysms because there is a real dilatation. Saccular is when there is a dilatation of one part of the circumference of the vessel. So in a cross section you will see the feature like this. when the whole circumference of the vessel is dilated, that's considered as the fusiform aneurysm. So this image will show you clearly about that issue. Dissecting aneurysm is a false aneurysm. Dissecting aneurysm and extravascular this component also are the false aneurysms, where in the dissecting aneurysm there is a rupture of the endothelium and the blood flows into the subendothelial tissue, mesothelial area, and hence there will be a blockade of the circulation, but the vessels may seem to be bulged. The lumen of the vessel becomes narrowed and there could be an obstruction, and this occurs as a sudden issue development in case of hypertension. Whereas false aneurysm produced after an injury, suppose if there is an injury into the vessel earlier and then the injury had healed with a clot outside, then gradually the clot dissolved may have a connection with the vessel and the blood will be flowing out into the chamber and coming in. So that could be the aneurysm, which also is a false aneurysm, which could be seen as such. Then there is another possibility which mimics that aneurysm is arteriovenous malformation. In the normal situation, arteries they would end in the capillary beds, and from the capillary beds to the veins would start. But if there is some abnormality where the artery is directed connected to the veins, the arteriovenal malformation could occur either as congenital or in the treatment of renal failure or preparing the patient for dialysis. A arteriovenous fistula is created with an intention for facilitating the dialysis process. That also can result in the dilatation of the vessel, and though it's not a real aneurysm, it's categorized under the aneurysm and its complications. Now, as far as the clinical presentation of the aneurysm is concerned, in general, aneurysm can occur due to either congenital, most commonly congenital familial inheritance. The majority of the aneurysm conditions which we see are due to that. The other could be atherosclerosis, hypertension. Patients who have polycystic kidney disease, they also have a higher incidence of aneurysm. Reasons are not known. Patients who have diseases of the blood vessels, arteriovenous malformation, the other conditions like connective tissue disorders, sickle cell disorders, infections, trauma, malignancy, cigarette smoking, drug use, alcohol also are now believed to be some of the factors which can increase the chances of the aneurysms. From the general clinical evidence point of view, aneurysm is presented as a pulsatile swelling, or it can also be a cause for thrombosis because there is a eddies current, the circulation flows through, it can produce the eddies current and then could be clot formation. Pain in the area also could be the other clinical presentation. On auscultation there could be bruise. These are the intrinsic symptoms and signs. But most important are the extrinsic symptoms. Once there is an aneurysm bulging, it can get compressed the nearby structures, and even it is compressing the nearby structures, either a nerve or a vein also could be compressed. Patient may have the signs of nerve compression or the venous compression, but most frequently and most important from the clinical point of view is intracerebral aneurysms. Aneurysm occurring in the cranium, within the cranium, may produce the compression of the brain tissue and may present as neurological conditions. So from the clinical point of view, cerebral aneurysm are the most important conditions. The peripheral aneurysms, either aneurysms of the other vessels like carotid artery or peripheral artery, abdominal aorta, they may produce the symptoms at that area, and their approach, this consideration would be only from the point of view of compression of the nearby structures, and all your approach to the management will be depending upon the same. Whereas with the cerebral aneurysm, because they are concealed within the cranium, they are not easily identified. Unlike other aneurysms, you cannot see a pulsatile tumor, pulsatile mass, because it is covered by the aneurysm. But as the aneurysm expands in size, then there would be compression of the nerves and the patient may develop the symptoms. If the aneurysm is not expanding, it may remain asymptomatic. An aneurysm in the intracranial area has a high chance of rupture and bleeding, and once there is a bleeding into the brain tissue, you will have the cerebral hemorrhage condition, subarachnoid or maybe intracerebral hemorrhages can occur. Subarachnoid hemorrhage is more common. So as far as the data is now concerned, about 10% of the individuals with aneurysm and subarachnoid hemorrhage die. The complications would be higher, and there again 25% of those deaths would occur within 24 hours, sudden death, and hence aneurysm become more frequent. 40 to 49% die within 3 months, and mortality has to be estimated as high as 65% of the patients who develop these hemorrhage in brain as such. And as far as the other factors are concerned, the incidence of cerebral aneurysm, majority of them remain asymptomatic. As per the autopsy series studies are concerned, 0.2 to 7.9% of the population as a whole, even healthy, they may have a cerebral aneurysm, but they may not have developed any symptoms. And it can be even ranging from 5 to 10% without any rupturing and without producing any clinical symptoms as such. And hence, majority of the aneurysms are usually silent till they rupture. Majority of them are silent. A few of them may present with the initial symptoms of producing compression in the nearby tissue, and most frequent symptoms will be compression due to the optic chiasma. Optic chiasma producing visual abnormality of the visual field defects, or it also could be depending upon the location, like akinetic mutism. The patient may have abnormalities of the movement, and there could be even amnesia like symptoms where the patient would not have the proper memory, or hypothalamic dysfunction. Neurological deficits also can occur without rupture. And the other most frequent clinical symptom of an aneurysm which is expanding would be headache. A central headache would be the major clinical symptoms. The rupture may occur with the intraventricular hemorrhage, 79% of the patients, parenchymal hemorrhage in 63% of the patients, acute hydrocephalus in 25% of the patients, strokes with the frontal lobe involvement would be 20% of the patients. The other most important clinical symptoms which can occur even in patients who do not have a ruptured aneurysm could be headache, the most important, which is quite severe pain and often described by the patient as the worst headache of my life. Then facial pain, where the cavernous carotid aneurysm may produce the pain in the facial area which present with the neuralgia symptoms. Alterations in the consciousness, sudden elevation of the intracranial pressure with the aneurysm rupture may lead to sudden loss of consciousness and syncope in 50% of the patients. Mild symptoms like confusion and mild impairment also could be one of the symptoms which should not be missed. Seizures could also occur in around 20% of the patients with subarachnoid hemorrhage, and most events occurring within 24 hours of onset. Meningeal irritation signs like neck pain, stiffness, photophobia, sonophobia, that's fear around for the sounds or higher reactions to sound, hyperesthesia also can occur. Autonomic disturbances also can occur, which can be found as fever, nausea, vomiting, sweating, etc. Focal neurological complaints of hemorrhage or ischemia also can occur with the weakness or the loss of movement in any of those areas of the body. Visual symptoms of blurring of the vision, respiratory dysfunctions, cardiovascular instability can also be the presentation. Hormonal dysfunctions due to the aneurysm, pituitary abnormality functions also can occur. Rarely there could be epistaxis. Confirmation of aneurysm is better done by a contrast CT, and with the contrast CT the image can be seen. In the patients who is in 205, that aneurysm is seen in the contrast CT. In this contrast CT of that patient it is seen. So that's one of the methods of identification. As far as the management is concerned, there is no other curative management. The palliative management in the case of who is diagnosed as aneurysm would be control the hypertension, calcium channel blockers like nifedipine are used, seizures to be prevented by specific drugs. The surgical procedure would be the other option, either microsurgical clipping or aortic bypass and occlusion, or flow diversion with the stents, that the blood flow in the aneurysmal area is avoided by putting a stent, or endovascular coiling, that endovascular protocols are done, which are very sophisticated surgeries, and these are the usual protocols of the treatment that's about, in brief, about the treatment of aneurysm. Once the patient has developed cerebral hemorrhage, the treatment protocol would be as you treat any other cerebral hemorrhage. But aneurysm as such would require only a surgical intervention. There is no question of any curative medical treatment. Then the next part is very brief, would be dissecting aneurysm, which is a acute complication of any patient with the atherosclerosis or even other forms of the vascular pathologies. A patient who develops sudden increase in the blood pressure may develop a rupture, and then the blood may leak into the extravascular space, which produces the obstruction, and hence the condition is an acute emergency. Dissecting aneurysm is an acute emergency, and it's one of the, or maybe the next frequent cause due to the coronary artery for sudden death syndromes. Patients who develop sudden death, one of the most common causes, second to the myocardial infarction, would be dissecting aneurysm, where the patient develops sudden pain in the chest, vascular obstruction, and death can occur. And at that time, the patient would have a very high hypertension, blood pressure would be very high, and most of the times, before you diagnose the condition, the patient would be dying, and hence opportunities to treat a patient of dissecting aneurysm is extremely rare. So, the correct identification also would be possible only in such a situation where the aneurysm occurs in a cardiac unit. If the patient is already in a cardiac unit where all the facilities are available, or patient developing the complication during a surgery, then only the opportunity to make a diagnosis of dissecting aneurysm before death can occur. So such incidences are very few throughout. Majority of the diagnosis of dissecting aneurysm is a postmortem diagnosis. The effort, theoretically, of course, if there is a diagnosis done on the table, the life-saving procedure would be re-entry protocol. Re-entry operation is a technique of making a cut in the endothelial surface below that area which has bulged, so that blood which has gone outside the vessel again re-enters into the artery, and hence the patient's life is saved. But opportunities to do that would be very few as such, and hence that's more of a theory. With this, we will conclude today's class, as well as the raktavaha srotas. The majority of the diseases related to raktavaha srotas are discussed in this series. So we will conclude that, and next we will go into the other srotas. There are no questions, so we will wind up today.